Hello everyone. I would like to thank Dr. Sabahi and Dr. Al-Garhi for inviting me to give a talk in your prestigious conference. My name is Dr. Awara. I'm a community rehab psychiatrist in Canada, Nova Scotia. I would like to share with you the outcome of a study that we undertook for 3 years in an inpatient rehab. Before I talk about the study, I would like to share with you the international definition of rehabilitation. It is a whole system approach to recovery from severe and persistent mental illness that would maximize the patient's quality of life and social inclusion, as well helping them to acquire skills, promoting their independence, and to maintain them living with autonomy and independently in the community. So the objective of our study was that to study the patient's characteristics and to examine the impact of psychosocial rehabilitation on certain domains like the length of stay, ability to live in a less restrictive environment, as well reducing revolving door admissions for this group of patients. In addition, we wanted to examine the therapeutic carryover effect of rehabilitation on patients with severe and persistent mental illness, and to examine the quality of care that we are able to provide to our patients who were treated in this unit. So how did we measure the outcomes? We looked into the rehab exposure as to whether or not it has reduced future length of stay should this group of patients are readmitted in the future, as well the admission rate, revolving door admissions, and we looked into other service utilization like ER visits. The other thing, we measured the quality of care using an indicator called quality indicator for rehabilitative care. The unit in which we conducted our study was a community-based inpatient rehab equipped by 40 beds, serving about 350,000 population. 80% of our patients' population were able to do most of things without assistance. 7% required some assistance. Another 7% required a lot of assistance. 20% of our patients was quite difficult to engage with rehabilitation, so they needed extra support. About 95% of our patients required help to administer own medications. They were not self-medicating at the beginning of rehab. 93% of our patient population has active involvement from their family. So to describe the nature of the referrals to the inpatient rehab unit, the unit was very much a diversified unit, accepting referral from different directions, mainly from the acute service, especially patients who are slow to remit and require a longer time to improve. Also, long stay patients, patients with chronic mental illness with a tendency to acutely deteriorate in the community, as well type of patients who require high supported residential setting in the community, which was not available. Thus, they require to come to the inpatient rehab unit until a suitable or appropriate placement is found for them. So as you can see from this slide, from the source of referrals, 85% of the referrals was coming from the acute services. However, the 15% was coming from other sources. So to look into the sample structure, we examined 158 patients. 66% were males with an average age of 38. Females' average age was 46, a bit older. And we found that this group of with severe persistent mental illness patient has significant comorbidity, psychiatric comorbidity, medical comorbidity, as well. About 30% of them were admitted under Mental Health Act, and majority, 85%, received the diagnosis of schizophrenia. So what we were doing with those patients as they come to the unit, uh, number one was to ascertain the diagnosis. What was the matter with those patients to make them unable to recover or to maintain their life in the community? So to look into the diagnosis, to review the management, as well to look, after looking into the management, to look if there is anything we can do to improve their symptoms and to make them ready for rehabilitation. And once this process is completed, they immediately will be assessed for the psychosocial rehab, functional assessment, social assessment, vocational assessment, recreational activities. So when we looked at the type of management and length of stay, we found, understandably, you would imagine that patients with the severities that would require clozapine, they will have a length of stay which is higher than other patients who don't require clozapine. For instance, clozapine initiation and titration for this group of patients with severe and treatment-resistant condition required on average about 228 days. If you need to augment clozapine, then it would be longer, up to 300 days. Those patients who only required a switch of medication from, say, conventional to atypical or vice versa, they only required a length of stay of 77 days. Optimizing atypical or conventional antipsychotic required 150 days. No medication changed the length of stay of this group was about 215 days. So we looked at the group of that were required really to change their medication, to optimize it, to make them ready for rehab. And you found that this group that benefited from improving their readiness for rehab, they did really very well from the length of stay point of view, as this has caused them about 78% reduction of length of stay. And as you can see, this was the group that had their medication changed appropriately to suit their needs and to improve their readiness for rehabilitation. So when we looked into the pre-rehabilitation intervention and post-rehab intervention admission rate, we found a significant reduction of admission rate, really by 60%. So after the exposure to rehab treatment, this group of patients, really, they became much less in going to the hospital and be admitted. As well, if you look at the length of stay pre-rehabilitation and post-rehabilitation, significant reduction, 65% reduction of the length of stay. And other service utilization like ER visits, again, a significant reduction by about 50%, which shows the clinical effectiveness of inpatient rehabilitation. So to summarize the outcome, when we looked at the admission rate, we found that there was a decrease in the admission rate in 64% of our studied patients, no change in 28%, and an increase in, of the admission rate in only 8%. Thus, the net reduction of the admission was about 76 less admissions, which is significant, really, given the cost that would involve admitting people and discharging them. Length of stay, a significant reduction, and in numbers. Pre-rehab, the total number of admissions days for those patients was 10,000 days, and then post-rehab, it was reduced to 3,500 days. Net reduction, 6,500 days less in post-rehab time. So the ER visits decreased in 62%, no change in 23%, increased in 15%, but net reduction of ER visits was 166. We assessed the quality of care, as I mentioned in the beginning of my talk, using quality indicator for rehabilitative care. And this is a web-based toolkit that was developed by 10 European countries and by the VISA collaboration involving 11 centers of inpatient rehab in European countries. It is the tool was developed from a study called development of a measure of best practice for people with long-term mental illness in institutional care. So this is a summary of how the countries that were involved, and as well how the indicator, quality indicator, was developed. It was based on systematic review, Delphi exercise, many studies, experts in the field to examine the quality indicator, and it is a very good quality indicator, I must say, and I will mention that in a few seconds. So it is looking into 7 domains: living environment, therapeutic environment, treatment and intervention, self-management and autonomy, social interface, human rights, recovery-based practice. And when this quality indicator, which is a quality indicator for rehabilitative care, was examined, it was a good psychometric indicator, excellent inter-rater reliability, good internal consistency, and good convergent validity. So this was the outcome of our quality of care in our unit. The good things about this indicator is that it would measure us against similar units in the same country. So it measured our unit against similar rehab units in Canada. And just to show you that we did well on certain domains, but we had as well area of weakness. So we did well on living environment. We were above average by 10. And we did well on treatment and intervention, again above average by 10 points. On the social interface, we did very well. We were well above average, scoring 81 compared with average 56. However, we had some area of weaknesses, like self-management, like human rights, like recovery-based practice. So we have areas that we need to improve, and we have areas of strength. So one of the questions would be for those who are referring patients to inpatient rehab unit, what sort of patients that would benefit most from inpatient rehabilitation? So we examined different categories of patients based on their diagnostic formulation against their post-rehab admission rate, length of stay, and ER visits. So we found that the patients who were diagnosed with schizophrenia or schizophrenic spectrum in general, like schizoaffective or whatever, those patients did very well on the 3 domains: less admission rate, less length of stay, and less ER presentations. Those patients who were with affective depression and substance misuse problem, they did well from the admission rate point of view, length of stay point of view, so it became less in post-rehab, but there was no difference when we looked into their ER visits. The patient who did not benefit from inpatient rehab was those patients with personality disorder and behavioral related problems, adjustment disorder, and this stuff. Those people did not benefit from any of those domains. Their admission rate was not less than before, length of stay is same, and ER visits remain to be the same. So this is a sort of a group of patients that people will need to refer to the inpatient unit, rehabilitation inpatient unit, I mean. So After doing the rehab intervention, we managed to discharge patients to a less restrictive environment. About 80% of our patients went to different places, like their own homes, or living with family, or some supported accommodation, like what we call here in Canada small options and group home, and they remained there successfully. So in 80% of our sample, really, they went to live independently. Some of them with some support, some of them with only community rehab support. So who is taking over? What is the services taking over those patients? Community rehabilitation services, which I am working in at the moment, has taken up to 60% of the discharged patients. About 20% went to early psychosis, and about 20% to other services. So when we looked into the cost effectiveness of our study and compared that with Benyan et al. Study in the UK, as you will see, our sample population that we studied was 158 patients. In the UK was 22 patients. We examined the post-rehab in the first year. They examined post-rehab for 2 years. We found, as I mentioned previously, significant reduction in admission rate, length of stay, and ER visits. Similarly, in Benyan et al. Group, they found a significant reduction in hospital admission that resulted in lowering cost. Also, a substantial proportion of their patients went to live independently, exactly the same of our study, and some had no further admission. So it is a very much similar study to ours from the outcome point of view. The only difference is that the sample size was 22, and they examined the carryover effect of therapeutic rehabilitation. For 2 years, we examined it only for 1 year. Looking in the cost, in 1 year post-rehab, we saved $9 million, and cost per patient saved was about $58,000. In the UK study, they saved on this number of patients, 22, $1,700,000, and per patient, $81,000 after converting the sterling into Canadian dollars. So what we have learned from our study and other studies conducted in the same field is that enabling recovery via a whole system approach is helping patients significantly. First, in the post-rehab is to maintain them with the right level of skills that we'll need to acquire to stay in the community. Some of them were working under supported employment sort of program. Some of them was working independently. Some majority of them were discharged to a less restrictive environment. So really, inpatient rehab has helped those group of patients who were really in and out of the hospital in a revolving door fashion admissions, or utilizing other services like the ER, or even when they are admitted to the acute service, they stay much longer. So the key message here is that the inpatient rehab was quite successful in helping patients with severe and persistent mental illness to stay successfully in the community, either under supported employment program or working independently. Those patients had less admission rate, less length of stay, and less utilization of other services like ER visits. There was associated significant reduction of bed costs for these patients based on the previously mentioned outcome. And they maintained themselves very well for a year post-rehab. We didn't examine them longer, but other studies that examined them for up to 2 years had ascertained the same. I would like to thank you all for listening, and I will be ready for your questions.
Good afternoon, everybody. I welcome you all to this workshop today. I'm going to talk about something which is very, very close to the work that we are doing. I'm Dr. Mehnaz Zafar, consultant psychiatrist and associate professor of psychiatry. I'm working at Al-Amal Hospital and leading the adult community psychiatry services. At the same time, I'm associate professor of psychiatry for a few universities here at in the UAE, which includes Mohammed bin Rashid University, Sharjah Medical School, as well as the Gulf Medical University. I also serve as director at large at the World Federation of Mental Health, and I'm representing the World Federation of Mental Health at the World Health Organization. So today I'm discussing about something which is very crucial to our education system, which is about incorporating the rehabilitation and recovery-focused training in the current education system. We know that there has been a lot of importance that has been placed on mental health and the substance use disorders, which are affecting the 13% of the population and are leading cause of disability worldwide. People with severe mental health conditions die prematurely as early as 2 decades due to the preventable physical conditions, as mentioned in the WHO report. The recent years has witnessed increased focus on the inclusion of the mental health in the Sustainable Development Goals. There has been policies which has been drafted and lots of stringent criteria to promote mental health all across the globe. The WHO Special Initiatives for Mental Health in 2019 to 23 aims at the coverage of mental health for patients to ensure access and to quality and affordable care for mental health conditions. Talking about the mental health in medical education curriculum, one of the things which was very crucial for understanding was what are the current trends in medical education to foster future physicians the basic referral knowledge in mental health, and what are the key components of mental health training which have been implemented, whether they are in line with the future trends or what challenges do they pose. In this regard, Al-Amal Hospital has been receiving medical students, undergraduate medical students from 4 different universities. And we had the privilege to understand their curriculum. One of the universities which has not been coming for medical school, but I was associated very closely with them. In this regard, a little bit understanding of the future doctors. Where are they placed at this point of time? How are they performing in terms of their education as they become interns or they further become general physicians? Whether they are able to recognize the mental illnesses and what is their current understanding of where is mental health placed. So the traditional medical curriculum was more like discipline-based education, which had a traditional approach, analytical approach, like first based into disciplines like anatomy, physiology, biochemistry, surgery, pediatrics, internal medicine. Psychiatry used to be a part of internal medicine, and those were the more traditional approach where I think so a lot of us were educated in our medical schools. Moving along, there came the current medical curriculum, which is more of an integrated curriculum. It's based into phases. Now, this medical curriculum is what is from Mohammed bin Rashid universities. There's a vertical integration in all phases. So the phase 1 is a biomedical and behavioral basis of clinical practices. And in this, there is more emphasis on the biomedicine, which is the normal structure, functions, and the basic clinical sciences. During this phase, there is, as we go vertical up, is more complexity that is usually seen. For example, the year 2 and 3 shows the abnormal structure, functions, and the behavior, which is actually the pathology, where there's dependence on the physical examinations on communication, the clinical and the lab investigations, and so on. The year 4, 5, and 6 further go ahead and are embedded into the clinical sciences and clerkships, which is mainly delivered in the clinical settings with discussions experienced in the tutorial settings. So this curriculum is now more commonplace in most of the universities, and there is more preference that in each phase, the students, the future doctors, are exposed to the clinical settings. So while they are reading about the normal structures, they might have some sort of a clinical encounter, maybe not in the hospital, but it might be through videos, through libraries, through role plays, and there would be some communication skills like breaking bad news, medical ethics, which would be at the ground, which would form the ground stone of the foundational network of the medical education. What is the integrated medical curriculum? So according to Shoemaker, it was defined as a curriculum where the education is organized in a way that it cuts across the subject matters, bringing together various aspects of the curriculum into meaningful association. So this, while it has been very well accepted in most of the universities, and there has been innumerous studies which has found how they are well reflected into the future doctors all across the globe, what is very essential for us is where is mental health and how is mental health placed. So in the few universities across UAE, the mental health course placement is usually in either in the 4th or the 5th clinical year, in a 6 years or a 5 years course. So different universities are placing it in the different years, but one thing which is common is they are all in the phase 3 of the clinical years where mental health is placed. While mind and behavior is covered in the year 2, in the phase 2 of some undergraduate medical curriculum, there is also a touch based on the neurosciences when it comes to the mind and behavior. However, it is more theoretical, and the bigger chunk of the placement lies in the clinical years, where the students are going to become doctors very soon. Coming to what is the course teaching. So the course teaching for different universities varies again. So some universities are teaching the courses at the end of the clinical years. Some teach them throughout the clinical years. Some teach them in batches. For example, in 8-week batches, they complete teaching about the mental health and they progress to other specialties. So this is how they are taught. Regarding the clinical placement duration, so clinical placement is the time where theory actually comes more in closer with practice, and the students are able to at least get a good grip on how the placement is done. So in some universities, there is a variation between different universities, which has got 8 weeks to 6 weeks, and some universities which have shorter placement for mental health, because of the fact it all depends on the number of students and how the curriculum, overall curriculum has been devised. So while some universities try to cover it, and the medical students are given mental health training formally in the mental health hospitals, in the other hospitals where there is psychiatry, or they might get some understanding during their family medicine clerkship. But more so, there is a diverse range that has been noted in the undergraduate medical curriculums. More important so, one of the most astonishing fact is that the internship, which is post the medical school compulsory mandatory internship, where most of the students, once they become doctors, they have to go through a mandatory 1 year of training. It is surprising so elective for psychiatry in all the universities. So one of the things that is lacking is that there might be while there is a chunk of medicine as well as in surgery, gynecology, but psychiatry might still remain to be elective in all the universities. In this regard, for all the universities which were coming, we tried to get an understanding of how the students, what was the ideas of the students, and how was the content that was placed. Regarding the trends in the shifts of curriculum, what has been noted classically is that there has been the content of the medical teaching remains on the diagnostic aspect of mental illnesses, substance abuse disorders, as well as psychiatric disorders. The training has been a commonplace, and the traditional teaching lies on the biophysical model, where there is etiology, pathogenesis, focus on the pharmacological treatment, and so on. One of the very important things that was seen is that the instructional strategies were earlier problem-based. So there was a clinical problem, it was an encounter, and then it was changed to a case-based approach. And now very common, what has happened is most of the universities have started to incorporate something known as team-based learning. So while the problem-based and the case-based approach did touch on some of the humanistic aspects of mental health treatment, but still they were more based on the diagnosis or on the treatment that was seen. Now, what has become more common is in the last couple of years, biopsychosocial model of illnesses and treatment is being emphasized. And most of the hospitals, their training includes like interaction with a multidisciplinary team, where there is the training of the students along with the doctors, as well as the nurses, as well as the psychologists, the social workers, and there is a system of multi-source feedback, where there is feedback which is received from other disciplines as well. The last few years also saw that risk assessment has become integral, at least in the center where the undergraduates are being taught. And one of the things which was very integral was the integration of the communication skills in psychiatry interviewing. The difficulties and the challenges that posed was in the universities which were taking communication skills in psychiatry in their early clinical years, it was found to be more beneficial for them because it helped them in the different ways of psychiatry interviewing. However, some of the universities found it very difficult, where the students themselves responded that this was taught to them maybe at the end of their clinical placements, where they had already learned a lot in the last 3 years. They had learned different sets of clinical skills, and the communication skills would have been early on. Some of them also reported that there was some sort of theory lessons based in communication skills, but they were not put to practice. The principles of medical ethics have been incorporated, and there has been trials to align them to the lectures, like confidentiality as well as capacity to make decisions. Those were certain things that were emphasized during their clinical placements. So some of the universities also included as a section that had to be filled by the medical students, besides fulfilling case reports and other clinical scenarios. The clinical skills training sessions have been included for some of the batches where there is more frequency of the visits by the students. However, for shorter batches, it is very, very difficult. So if there is any like university which is coming for 3 weeks only, it would be very difficult for them to have a good understanding of all sorts of cases that might be present in a mental health clinic. Regarding the perspectives of medical students prior to the clerkship, so one of the survey that was conducted on 86 preclinical medical students to assess their knowledge regarding mental illnesses, expectation from their rotation, and their attitude towards seeking help, which was thought to be a separate set of a study, it was surprising to see that 65% expected severe mental illnesses like schizophrenia or major depression to be more prevalent, where they felt that mostly patients would have illnesses which were more chronic, and 82% believed that mental illnesses were chronic and required lifelong treatment. When discussed about the recovery, 92% defined recovery in terms of clinical resolution of symptoms diagnosed by the clinicians. Some of the other striking facts were there was very less understanding regarding personality disorders. Some of the patients of, even at the end of clerkships, students failed to identify the personality disorders in different patients, and they would primarily base their diagnosis on the axis 1, which was of DSM-4, which was not being followed so, but they would only talk about one clinical diagnosis or their differentials. Help-seeking attitude towards mental health concerns, this was kept for another separate, to be separately encountered for the mental students, but for the mental health concerns for medical students. And in that, the concern included the feeling of being stressed, overwhelmed, anxious, or having a mood change. 94% might felt that they might not feel comfortable to seek help from a mental health professional. 58% felt they could share with the mental health concern with a friend or a close person. However, 82% suggested that they would prefer to keep it to themselves and let it pass. While few mentioned that they could share, a thing to ponder regarding this is when they were ready to share with a friend or close person, still they prefer to keep it to themselves. This was kept for a part of another study, which is currently ongoing. However, the very important part regarding this is that students really did not understand that what a mental health concern meant. So the recognition of feeling of being stressed, overwhelmed, anxious, or having mood change, I mean, that felt very non-specific to them. They felt that that might happen during, and whether this required them to take help or not was something that they felt very confused about. Talking about mental health and recovery, this analysis of the current medical education in the undergraduates brings us to certain very important points that mostly, despite that there has been a lot of revisions across the training and education in the medical schools, one of the first and the foremost things that we always realize that there is a need for a scientific evidence-based explanations to things. So unless there is a clear understanding of a sign or a symptom, the recognition of those signs and symptoms were very difficult. Signs and symptoms always were found to be more and more important while evaluating a patient than a patient's experience and their feelings. The whole concept of what is recovery for medical students were felt into a gray area. And that is why one of the things that we have started to incorporate was that there needs to be a focus on recovery-oriented training towards even at the level of the undergraduates. While many of the clinicians, when during our discussions, we did feel that it might be reserved for the postgraduates, but one of the things that was strongly supported by most of the clinicians who were also acting as facilitators and supervisors as well as lecturers to the students was that mental health, rehabilitation and recovery does form as a fundamental part of training of all students who pass any clerkship in the hospital. Mental health includes our emotional, psychological, and social well-being. It affects how we think and feel and act. It also helps to determine how we handle stress, relate to each other, and make choices. When we were imposing a definition or standard of good mental health to students, it was something that was perhaps more a way of learning that they had commonly encountered. But one of the few things that was explained to them during this process was that this would lead to exclusion, discrimination, medicalization of behaviors as abnormal. One of the few things that was discussed with them is that recovery is something that needs to be further generalized and into a clinical and a personal perspective. So the World Health Organization has discussed about the mental health and well-being regarding the attitudes about themselves, having control over one's life, having a purpose in life, having relationship with others, engagement, and ability to attend to their basic needs. When mental health is being taught to the doctors who are going to treat patients in different fields of medicine or surgery, one of the very important things as the tutors is to give them a holistic view of mental health and well-being. It was surprising for many when this model of teaching was discussed and was put forth and in the first few sessions of their introduction or their induction sessions in the hospital. While the clinical recovery has been clearly explained as resolution of symptoms, absence of symptoms for 6 months, partial and complete recovery, where it is different in substance use disorders, where there is a time of 12 months, and evidence-based practice and skillful use of interventions, which are more interventions that have got very good evidence data for getting rid of the symptoms, restoring the social functions. The personal recovery was discussed with the students in a different perspective, like which can be commonly explained as a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills, and roles. Personal recovery for patients with mental illnesses was a way of living a satisfying, hopeful, and contributing life, even with limitations caused by the illness. So this was something that has been something which is of profound interest. And when given this sort of connotations, it actually shows belief and hope. This is more towards lesser judgments that has to be made as a doctor, a lesser judgment that might have to be passed regarding a patient, the doctor-patient relationship changing into more of a participatory discussion that has to be embedded in the medical curriculums. and more of a individualized, patient-centered, a person-centered approach that was discussed even with at the ground level. So it was not only for the postgraduate teaching, but at the ground level, when there is a foundation that is being laid towards mental health, treatment, diagnosis, as well as future of mental health trends, personal recovery was found to be one of the most important uh, uh, one of the most important way of educating the students so that they could become they could have a good idea about mental health treatment, because like in terminal illnesses, many of the medical students found that becoming a psychiatrist or mental health professional was something that was quite they could not see a line at the end of the tunnel. They could not see a light at the end of the tunnel because they felt it was uh, not something that was pleasurable. It was not something that was empowering. And that is where the change of attitude and thinking towards medical students towards mental health was required. So the core elements of recovery model uh, into 5 domains were promoting a culture and language of hope and optimism, which starts with their interview, even as students, even their interview when they are discussing or communicating with a family member, which was asked to them in presence of a supervisor. One of the second most important domains was person first and holistic approach towards the illness and its treatment. The domain number 3 was supporting personal recovery, as we discussed right now. Domain number 4 was organizational commitment and workforce development, that there needs to be a good model that needs to be in the system, which is built and overlooking at not only treating a patient in the hospital, and this is the only work of a doctor, no, but at the same time, there is a commitment to make a change, to also ensure that there is recovery at every stage, to make some goals or a care plan, which is with the patient, and once he's outside the hospital with people, those who have had lived experiences with mental health. And this has to go and continue, which really felt very interesting for many medical students who even went for community home visits during their placements. The 5th domain was acting on social inclusion and the social determinants of health, mental health, and well-being, which was about talking to patients not in a clinic setting only, but during their home visits, during their visits at their workplaces, by giving them access to approach you, and by making yourself available as well as accessible in certain things that were important to them. Now, this was something which was very difficult in the beginning to be understood, because this was in contrast to what they have learned or they have studied or they had practiced in different rotations and clerkships. This was different than what was being taught in their curriculum, which was more heavily loaded on content regarding treatment and follow-ups, but not about recovery. Recovery is based on hope and optimism for the future. Hope is an essential principle of recovery. The essence of hope in recovery is that it is possible to live a meaningful life in the presence or absence of symptoms. While stating so, many medical students had these questions regarding whether they can give false hope to patients, and that is where again, a little bit of where the medical ethics are coming into place was confusing for them. However, what was said is that the fact that doing a partnership, instilling the hope and recovery with partnership was more essential than the just giving them hope and without any background support to fall back on. Central to the concept of recovery was a belief that one situation or circumstances can change, or that one will be able to manage the situation. So this was something which was very interesting, and one of the things in community mental health treatment which can be done is that we can show what was a very different picture where, for people who have been discharged from the hospitals. So when discharged from the hospitals, when they maybe 5 years back, 3 years back, or maybe 3 weeks back, one of the very important essence of mental health care and delivery lies in rehabilitation. So when the persons with mental illnesses, when during their recovery phase, they come to the hospitals to get rehabilitation, or they are engaging in daycare workshops, they are engaging in therapies, in different forms of therapies, that itself was very essential for medical students to take back on, because they could understand that while they need to know when and how to refer, but at the same time, recognition of the fact that early intervention can lead to very good results in the recovery of patients was one of the key components that has been embedded in the medical education currently in the curriculum that is being running. These are the comments that we have provided to the universities so that they can embed them in their behavioral medicine teaching. Also, what was important in recovery was not what the physician felt was important or what the care team felt was important for them to do or not to do, but something which were more aligned towards the dreams, aspirations, and possibilities of the persons who were having those symptoms. It was also not, it was definitely the caregiver's burden to be reduced was one of the important aspects that was explained. However, the recovery was more individualized and focused to the person himself and was not what the family intended them to do. Factors on the road of recovery were the recovering of the identity, of the relationships, of the engagement and finding meaningful purposes, of giving supports and services. This is where community mental health treatment, which is focusing on instilling some of the services and the support networks, proved very helpful in discussing with the patients early on during the care plan development about what support, what were their needs that they required, supports regarding their self-acceptance, regarding their self-efficacy and awareness, regarding their need to take control and to have meaningful relationships. So these factors required to be analyzed, and while we know that undergraduate medical training might not be able to engulf all the important aspects of recovery-oriented training, however, there needs to be a starting point and there needs to be essential key guidelines that has to be incorporated when we explain recovery in the context of a patient. And the physician has to go beyond doing one of the only things, like maybe symptom resolution, but might also have to go ahead and align with different services to provide different support systems so that perhaps the whole system to rely on the physician might not be more important, and the person afterwards can rely on other supports. So this important key point to learn was required for the medical students when during their training, that there needs to be services and supports post-discharge, and follow-ups and illnesses might just remain a part of a patient, but not their whole. Relationship between professionals and, most important, the patients that they served was very essential, because there was a recognition of the value of expertise of patients, that this helped them to understand that there is a genuine need to care for the patients, need to care for a shared decision making at all levels. It's not a more paternalistic model of a patient-doctor relationship. There was a shift of the balance of power when recovery-oriented training is given early on in making the doctors, where the mental health workers use their expertise differently, and it supports self-management rather than fixing people. Coming to some of the inferences which were gathered regarding the common understanding of the disparities that are there in the current medical education that is being provided, is that there is disparities not only in the curriculum that is there is course content, there is disparities in their course duration, in the duration of the clinical placements, in the instructional strategies which are being employed, in the content that is being delivered. The communication skills, while have been included in most of the undergraduate medical curriculum in the country, recovery and rehabilitation has not yet seen the face of light. Clinical placements do not provide sufficient opportunities, and they are of shorter durations. There's a less emphasis as compared to other disciplines, and content is heavily laid on the medical model of illnesses. The implications of this are that psychiatric training during clinical placements for medical educations should have a uniform standard and include rehabilitation-focused and recovery-oriented integrated model of care based in community. One of the important things to teach the medical students is that medical illnesses might be a differential diagnosis of common mental health presentations, could be not only a differential, but could also result in some behavioral health presentations, and vice versa. That behavioral health presentations might lead to medical symptoms. So there needs to be an integration of the brain and the mind, brain and the body and the mind model of psychosomatic medicine that was also emphasized for the medical students at an early level. Rehabilitation has to be focused on integration back into the community, for patients with mental illnesses, for some of the tasks that were discontinued by the patient who was living with the mental illness and leading to ostracization by the community and staying without the required skill set. Getting them to have the required skill set was a task that was to be done by every medical student at an early on, because that would be a very important premise. It was not somebody else's work, not only a nursing work or not only a work of an occupational therapist, but even for doctors to go into the fundamentals of what would be better for a person who is suffering from mental illnesses was essential. One few findings that have been discussed today suggest a need for policy implementation for standardizing psychiatry training for future doctors, adopting newer instructional strategies more than like a case-based. The cases have to be based on persons' actual experiences, mandating clinical experiences, and improving their attitudes towards accessing mental health care. This brings me to an end of my discussion. I really, really thank all of those who would be staying till this end and going through these live workshops. And I request that if you are a teacher, a tutor, or contributing in any way to the training in the field of mental health to maybe doctors or to nurses or to perhaps any other community, one of the very essential things to be laid early on is a focus on rehabilitation and recovery. I thank the organizers, especially Dr. Mehta, for his for making me a part of this very, very special event, which is very close to my heart, the World Association of Psychiatric Rehabilitation, and for bringing this important platform to UAE. And I hope to see people in the next conference in person. So I would be happy to take up any, these are my references. I would be happy to take up any questions if there are. Thank you. Thank you very much. I think you are mute.
Hello, can you hear me now?
Yes, I can hear you.
Yeah, thank you very much for your very useful and formative informations. Thank you for your time. I just had a very short question. Just wondering, like, how did the pandemic, COVID-19 pandemic, affected the studies? I mean, mental studies at universities in general, and in particular in UAE, if you have any information on that matter, like how it shaped or structured the studies of mental health here or overall. Like, if you can just summarize it and tell me, I would really appreciate that.
Thanks. That is a very, very valid question. Thank you for your question. Regarding that, yes, we do have enough evidence regarding this because, as I said before, that our hospital has 3 universities which were coming in for the clinical placements of undergraduate medical students. And during COVID, one of the difficulties was that there was limitations in access to the medical students who could, because those who could, meet the patients inside the wards. Why? Because the wards were having the patients who were all having the COVID negative results. So there could not be a direct one-to-one access to their medical education. However, we tried to supplement through a lot of videos and role plays for during the key part when there was the peak of COVID. We did try our best to supplement case list discussions, role plays, as well as lots of videos during our medical education training. And we did try our best to have when there were a little bit of liberations that were taken later on, when the patients could see that from maybe another, like with adequate social distancing, maybe an interview in progress, we were able to expose the medical students to that. One of the things that we are still doing it, that all the assessments have still been on simulated patients. So none of the assessments were on real patients. So that is one of the things that have still progressed so far. Yes, this has definitely caused a lot of problems for their training per se. But at the same time, again, we are hoping that we are going to revert back to what was more original for us. So yeah.
Thank you so much. It was very informative. Thank you for your time. Thank you.
Yeah, you're most welcome. I think I have another question here that for sure, even psychiatry students and workers alike have gone through tough mental health issues during the pandemic. What do you think were the tools that really helped psychiatry students and workers as a whole to cope and progress from the situation? Well, I think this is a very, very, very essential aspect. Why? Because one of the difficult things out of the that we have witnessed is that the mental health, the cases that were coming to the hospitals, the patients that were getting admitted, they really increased in number. So it was very difficult to actually deal with crisis, both in the country, in the world, as well as in the hospitals per se. This was a problem that was seen and identified by the hospitals. One of the things that the hospitals has started, thankfully for us, is that they started mindfulness sessions for all the doctors, nurses, everyone, all the mental health workers. They started giving more supportive sessions. So we did find a lot of support that was being provided. Yes, there were flip sides of still maintaining the contact by telepsychiatry, by Zoom calls and meetings, and by WebEx meetings on a daily basis. However, one of the things that has been really helpful is that government has been very supportive in giving us appreciation to the frontliners and sending us lots of messages on our mobiles, which has frankly kept us going. Yes, but it has been exhausting for, I think, all the mental health physicians, workers, as well as the learners as well. So this is true. I think if I have answered all the questions, I would request you that if there are any other questions, please send me them across, and I'll be happy to answer through emails or other things. However, one of the things is the 3 R's are resilience. I would end the session by saying that resilience, rehabilitation, and recovery are the mainstay. I mean, they are the mainstay which has to be practiced and preached in order for us to have a healthy community. Thank you. Thank you very much.
afternoon, everyone. My name is Majid Agour. I'm a psychiatrist. Good afternoon. My name is Majid Agour. I'm a psychiatrist. I'm going to talk to you today about psychedelic drugs. Good afternoon. My name is... Yes, so we're going to have lots of exciting stuff to talk about today. Potentially a new paradigm in the treatment of psychiatric disorder. Is that good, guys? Yeah, no worries, no worries. Okay, so a bit of history we're going to talk about, a bit of sort of recent practice, and some of the challenges that psychedelic drugs met through the decades, and how we seem to be witnessing a different era now. So I've got some studies for you, new studies and some of the old studies, and I'll compare and contrast how the research methodology has changed over the years. So yes, I was saying, guys, that we're going to compare and contrast the past history versus news.
Io mi sono immaginato che comunque guarda è importante.
Good afternoon, ladies and gentlemen, and welcome to the afternoon session of our conference. My name is Majed Agour. I'm a consultant psychiatrist. I graduated from medical school in Egypt. I did my postgraduate training and qualification in the UK, and I've been here in the UAE for the last 5 years or so. I've been part of a really interesting project that established an addiction rehabilitation and treatment service in Dubai in UAE. And that actually was the background for my presentation today. While I was updating myself on sort of commonly abused substances, I came across the hallucinogens. And in classic textbooks, obviously hallucinogens can be referred to as a substance of abuse, and it's Schedule 1 drugs. It's illegal, but after digging further in the literature around hallucinogens, I came across sort of very different side of literature that talked about hallucinogens or psychotomimetics or psychotogenic drugs, as they sometimes refer to, as potentially sort of therapeutic agents for some of the severe mental illnesses. And that really is the background of my presentation today. I've been interested in these kind of substances, the history and the past and the recent studies for the last 2 or 3 years. So today, hopefully, I'm going to share with you very briefly a bit of the historical background of these kind of substances and where the psychedelic name came from. I'll share with you very briefly some of the common clinical effects, some of the past research and the recent studies, and the potential future of these substances. Humphrey Osmond was a British psychiatrist that really coined the name of psychedelic drugs instead of referring it to hallucinogens. And the idea is to change the connotation that was related to hallucinogens and psychotomimetics, which has a pathological connotation, to a more positive connotation, which is psychedelic refers to mind revealing or mind manifesting, soul revealing, showing the real good soul and mind and spirit, really. When I went through literature review, there are multiple evidences that psychedelic drugs have been used for thousands of years across the globe, really, in different cultures for different reasons. So this is a mural on one of the Spanish caves that depicts, as you can see at the bottom of the screen, what appears to be magic mushrooms. It is thought that it could be one of the oldest evidences of their use in ancient Europe. In the Greek mythology, here you can see the goddesses Demeter and her daughter Persephone admiring magic mushrooms. This is another example of statues that have the shape of magic mushrooms that have been built by the Aztecs, the ancient sort of indigenous American tribes, the Mayans, the Aztecs, and so on and so forth. The classic use of the psychedelics in indigenous cultures have been led by the sort of eldest wise people in this kind of cultures, referred to as shamans. And it's a hybrid job between a doctor and a priest without formal qualification. But that's how it used to be practiced in the past. And in some areas, some parts of the world, there are still some shamanic practices. Okay, so now if we move on to the clinical effects of psychedelics and some of the working sort of classification of these substances. So there are the classic psychedelics, and that includes the LSD, that's lysergic acid diethylamide, psilocybin, the active ingredient in magic mushroom, DMT or dimethyltryptamine, which is one of the active ingredients of ayahuasca brew or tea, and mescaline, which is isolated from peyote cactus. How psychedelics work from a neurobiological point of view is not very clear. What is rather clear, as it is in the case usually with anything to do with the brain or the human body in general, it's very complex mechanisms, and they seem to affect so many receptors. But there are a number of studies that point towards the direction of classic psychedelics affecting particularly the serotonin 2A subreceptor or receptor type in an agonistic way. What are the classic psychedelic effects? They produce changes in perception, thought, feeling, ranging from distortions of normal perceptions, the so-called illusions, or perceiving something that doesn't exist, hallucinations. They generally heighten sensory signals, but this is often accompanied by loss of control over what is experienced. There is a sense of ego dissolution, loss of oneself. For those of you who are not familiar with this kind of substances, this is just how some of them look like, though this is an example of magic mushrooms. This is peyote cactus. This is really how people in the 50s and 60s and the later decades were taking LSD. Now, when the Swiss pharmaceutical company Sandoz synthesized the LSD, it was obviously for legitimate medical reasons. It had formulations, liquid or tablet, but when it went into, it was banned, as we're going to know soon, in the 70s, and it became illegal. So for people to promote it and use it, they wanted to hide it. And because it's a very powerful substance, LSD, it can be effective in micrograms. So they would spray it on blotter paper, really. And so a tiny bit of blotter paper with all sorts of fun kind of drawings has been a fashionable thing when people used LSD. Now, this is what's called the ayahuasca. The plants used to make the ayahuasca brew or tea. And it is not one, it's not one plant. It's super interesting, really, when you see how people over hundreds of years or thousands of years through trial and error got to this ayahuasca brew. Now, the bit we're interested in is the Psychotria viridis, which is really where you get DMT from, dimethyltryptamine. And the other one is, the other plant is Banisteriopsis carpi. Now, why are they using two plants in this drink? It's amazing, really, because it was found that the DMT, if people ingest it orally on its own as the Psychotria verdis plant, it gets broken down in the intestine by the monoamine oxidases. So people over time, they realize that if they mix another plant, Banisteriopsis carpi, which happened to have a monoamine oxidase inhibitor called the bicarbolanes, that really enhances the absorption of the DMT from the intestine, hence the effects. Okay. Now, the other category of psychedelics, and these are, we're drifting away now from the classic ones, so we're going to go to what sometimes referred to as quasi-psychedelic substances. So something called empathogen or entactogens that enhances people's emotions and togetherness, and obviously the other name for it is party drugs, or where people take it to facilitate relationship and sort of all sorts of behavior, disinhibited behavior that has to do with love and warmth and being together. One of the common examples is methylene deoxymethamphetamine, MDMA, or known as ecstasy or Molly. Again, it works through a complex mechanism in terms of receptor stimulation. However, there is evidence that it particularly increases serotonin, dopamine, norepinephrine release. And the way I think about MDMA, because I think there is going to be a lot of potential, as you're going to see later, for this substance, I find it like half psychedelic, half stimulant, by looking at the substance and looking at the chemical composition and the effect. So when people ingest it, they get energized and very attentive. That is, and very focused, and that is the methamphetamine part, the stimulant part. And then there is the quasi-psychedelic part, which really is the main reason why people take this particular drug. It can cause mild perceptual changes, not as vivid as the classical psychedelics. It enhances empathy, love, emotions. Euphoria perhaps is the effect of the dopamine, and the empathy and love perhaps is the effect of the serotonin. And the final sort of category is the dissociatives, and ketamine is one well-known example, and it is thought to antagonize the NMDA glutamate receptors. Again, the effects tend to be quasi-psychedelic, so there can be some mild perceptual changes, whether these are visual or auditory or unusual sensations, but there is the special dissociative part about it, which is feeling disconnected from one's body, the depersonalization, and feeling that the environment is unreal, and that is referred to sometimes as derealization. Okay, moving on to the recent history. We've got Arthur Hefter, who was a German pharmacologist and chemist who really was the first person to isolate mescaline from the peyote cactus in 1897. This guy is more well known and more famous in the psychedelic history. Dr. Albert Hofmann, who was a Swiss chemist and was the first to synthesize LSD in 1938, but it wasn't until 1943 when he discovered by chance the psychedelic effect. He was also the first person to isolate and synthesize and name the principal psychedelic substances in magic mushrooms, which are the psilocybin and psilocin. Now, following what Albert Hoffman's discovery, and as I said earlier, Sandoz pharmaceutical company started licensing and promoting this substance for medical and psychiatric uses. It got leaked, and there was a plethora of research, really. All the psychiatrists in the 50s and 60s got very excited, and they were administered to thousands of people. All sorts of researches and experiments were done, and people thought this is a new era in psychiatric treatments or pharmacological treatments. And particularly, they found it helpful in difficult conditions, difficult to treat conditions, like end-of-life anxiety, depression, substance use. And there were also reports describing psychedelics used to enhance creative problem solving and so on and so forth. And this initial research in the 50s and 60s was actually not at an individual level. It was backed by decent organizations like the National Institute of Mental Health in the USA. Now, what happened is that it got leaked into the black market. People abused it, took it without really supervision, because from day one it was meant to be a medicine supervised by therapists, but on the street people abused it, mixed it with alcohol and other drugs, and there was all sorts of very unpleasant and unfortunate incidents that got to the media. And the hippies hijacked the psychedelics, and it fit into their counterculture. So basically, it was perceived, psychedelics in the late 60s by the mainstream public, the media, and the politics as potentially dangerous stuff, going against politics and wars and commercialism and all sorts of things. So it was prohibited. And the research died down for a few decades, really. And you can see here that the research peaked in the sort of late 60s, early 70s, then died down because of the prohibition, which is until now, by the way, until as we speak, it is still prohibited for public use. But then it was the last 20 to 30 years, really, that started picking up again the research, and as you can see, it peaked in this year and last year to about 700 publications per year or so. Now, some of the recent studies that really defied the prohibition, and it was really fueled by some of the very enthusiastic academics who either had personal experience or strong belief in this substance, and they did some really very high quality research in Johns Hopkins University in USA, Imperial College in London, and that really, along with other centers around the world, started bringing the attention back to psychedelics. The organizations, particularly like the MAPS and the Hefter Institute, Beckley Foundation, really played an important role in the renaissance of this. And then we started seeing high-quality peer-reviewed clinical trials, and to help treat some of the mental disorders that really the current orthodox treatment has not really been very helpful. Treatment-resistant depression, severe chronic anxiety disorders, eating disorders, all types of addiction, or obsessive-compulsive disorder, and so on and so forth. And that is really one big line of the current research now. The other sort of sideline of the research going on at the moment is a branch of research explores their potential for well-being enhancement in non-clinical samples. So professionals, healthy people who want to be more productive, more innovative, they do what's called microdosing. They take tiny doses of this stuff, which is obviously unlicensed, not with really any medical supervision. It's a movement that happened in certain parts of the Western world. But again, because of the claims that it's really helpful, there are some studies that are looking into the benefit of the microdosing in this kind of area. Now, comparing the shamanic view of how they used to introduce psychedelics with drumming and chanting and stuff like that, this is more of the modern therapeutic milieu or environment where therapists administer the psychedelics in a relaxing and positive kind of environment with support throughout the period of the effect of the treatment. And as they say, the two important things about that increases the likelihood of having a positive outcome when people take psychedelic stuff is the personal expectation of the patient, of the person, and the setting, the environment, and the people around, and the support. So I just picked up a few, either very recent or current, really studies that have been approved by the FDA or the UK Medicines and Healthcare Products Regulatory Agency. So you've got this study was a couple of years ago, started a couple of years ago. They used psilocybin, which is taken from the mushrooms found in Mexico, to treat major depressive disorder, and it was a phase 2 trial. So it's to look at the efficacy and the safety of the drug. And it was a double-blind, randomized, controlled trial involved about 59 patients with long-standing, moderate to severe major depressive disorder. And it was really bold because it compared head-to-head, which is not really usual when you're starting out with a new product to go straight away head-to-head with one of the most popular SSRIs, escitalopram, but that's what they did. And they were equally distributed. And they did really very interesting techniques, perhaps beyond the scope of this talk because of the time. But what they found is that the psilocybin group effect on depressive symptoms using the quick inventory of depressive symptomatology and self-report, it was equally efficacious to the escitalopram, and in fact it was superior in other outcomes, well-being outcomes. Another really big study that perhaps is that might hit the clinical market in a year or two is the MDMA, methylene dioxymethamphetamine. And this is a phase 3 study that involves obviously a bigger number of people to check the efficacy and safety for people with PTSD, sponsored by MAPS. And it was randomized, double-blind, placebo-controlled, multi-site. And they found that in 2/3 of the patients who received the MDMA after 4.5 months, 18 weeks, 2/3, they did not qualify any longer for diagnosis of PTSD, so there was a remission, compared with about 1/3 of the people who had just the talking therapy. And it is when the FDA found that there is a potential for a super efficacy for a new product or a superiority in clinical trials like this, they give something called breakthrough designation, which can expedite the sort of process of the study and the evaluation, so on and so forth. So the bottom line of this study is MDMA was found effective and reasonably safe in PTSD, and they are hoping in a year or two they may get it licensed for use. Finally, a couple of two more psychedelics, the ibogaine, which is taken from an iboga shrub that grows in West Africa. They did a trial, phase 1. Phase 1 and 2A, it usually looks at the safe dosing of a drug in treating a particular disorder. And again, it was, they tested on opioid use disorders, and they found it very helpful in both managing the withdrawal from opioid and reducing the relapse rate. DMT is, as we said, from chacruna, which is the other name for Psychotria verdis. A study was done on major depressive disorder, phase 1, which is checking the dosage and safety, again done by one of the UK companies. And this has actually got the approval to go ahead with phase 1 this year, really earlier this year, for major depressive disorder. And phase 1 of the study aims to demonstrate the safety and tolerability. They've got 42 patients, and again, there are some initial sort of data to say DMT is very helpful in alleviating the depressive symptoms. And one of the special things about DMT that is not different from the other psychedelics, the duration of the psychedelic effect, the abnormal perceptions and mystical experiences, which are thought to be key for the therapy, tend to be very short, about half an hour or less, as opposed to hours in LSD, like 12 hours. Psilocybin could be 6 hours. So to cut down the therapeutic session to half an hour, that may make it more cheaper to run, to administer, easier for patients and therapists, and so on and so forth. So the conclusion is, while psychedelic drugs are showing a potentially new paradigm in the treatment of psychiatric disorders, there's a long way before they get licensed by regulatory bodies. Larger trials with more diverse patients, head-to-head studies are needed, more funding from public organizations, private sector, more funding is needed because it's pretty expensive, the substance, and to run these kind of trials. It is not a panacea for all psychiatric disorders. However, it is looking promising because it's offering really a new paradigm in terms of treatments for psychiatric disorders, not just through the neurobiological effect, but the clinical outcome as well. Thank you very much for listening. Good afternoon again, ladies and gentlemen. It's my pleasure to introduce speakers for the next talk, which the title of which is the sanitary and social integration to meet the needs of people with mental health and to promote recovery process. The budget of health as a possible methodological approach. And we've got our esteemed speakers from Italy. We've got Dr. Antonella Mastrocola, a psychiatrist and director ad interim of the Mental Health Department and Addiction Services of Romagna in Italy, and the former director of the Psychiatric Rehabilitation Unit of Ravenna. We've also got our co-speaker, Dr. Paola Carosa, who's a psychiatrist and director of the Mental Health Department and Addiction Services of Ferrara in Italy, and the former director of Psychiatric Rehabilitation Unit of CETI of Psychiatric Rehabilitation Unit of Ravenna, and of the Mental Health Department and Addiction Services. So over to you.
Okay.
Okay. Thanks, Doctor, for your introduction, and good morning, everyone. The topic of our presentation is about the sanitary and social integration. This is a very difficult point now, but we have to confront with this problem because we are a lot of problem about this point. Oops. Aspetta. Prima forse va dei problemi, poi dopo va bene. Okay, sorry. Today, public mental health services are facing how to increase the likelihood of desired mental health outcomes and quality of life in the community behind institutionalization. At the same time, they are aware that this means not only to improve clinical symptoms, but also to meeting needs such as housing, working, learning, having a satisfactory relationship. Over the year, to cure has taken on different meaning related to the paradigm that directed psychiatry at this stage of development. In 60s, it meant to improve self-care and reduce self and heteroaggressive acts. And the mental hospital was the setting when we had thought that was possible. Then it declined in a different way, as you can see, and today we should overcome the paradigm of stabilization and focus on functioning and rehabilitation, recovery oriented. Everyone knows the slogan of client today as nothing about us without us. Health concept in mental health moving away from medical model focused on symptoms control and absence of relapses to biopsychosocial model focused on playing valid and satisfying social roles in the community, in the access of housing, working, friendship, and affection. In fact, according to the World Health Organization, mental health is a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. This is the right of everyone that approaches public mental health services. But now social requests are increasing because there are a lot of fragile people without enough resources and supports for living healthy, especially about mental health. The mental health services are facing a new target of people: adolescents and young adults, people with mental illness offender, forced migrants coming from areas with war, violences, environmental disasters, poverty, etc., elderly alone, and people who have lost their job, house, family due to economic crisis linked to the COVID-19 pandemic. In many areas of Italy, we are trying out the budget of health as a methodological approach to realize a real sanitary and social integration involving public mental health services, social services, people with mental illness, families, volunteers, social cooperatives, and so on. The health budget is an integrated social health tool to support the individualized therapeutic rehabilitation project of people with severe and complex mental health disorders, starting from pre-adolescence. It consists of client, family, social and health resources aimed to improving health and promoting process of recovery, well-being, psychosocial functioning, inclusion of the person is active participation in social life according to the logic of generative welfare. The aim is to keep the person in his/her living environment and prevent institutionalization as well as stigma, isolation, and chronicization. The health budget is, in another word, the basket of resources and opportunities to carry out the life plan of people with complex social and health needs, and for whom the enabling and development intervention is appropriate. A tool that aims to recompose the fragmented range of measures and supports available, aimed at integrating and managing different resources, economic, time, competence of institutions, families, the local community with a collaborative and enabling logic. We think the user-centered programs are the best model to support this methodological approach, overcoming fragmentation between mental health services and other health and social agencies. The core is the person and his/her treatment plan, not services or single professional. Different competences are involved on the basis of the different needs of people, and not because practitioners belong to a specific unit or service. The interprofessional team is required. How to involve every community resource to improve the citizens' rights? The first step is the individualized therapeutic rehabilitation project. The client sets his/her aims in the axis of housing, working, learning, friendship, or leisure. We analyzed with the client and his/her family which abilities, supports, resources need to achieve his/her aims. Then the second step is to discuss in multidimensional evaluation unit a detailed that includes treatments, resource, case managers, and time of outcome verification. The multidimensional evaluation used is one of the most important setting when we can realize the budget of the health, because it is composed of those in charge of mental health and social services, and include people with mental illness, families, volunteers, social cooperatives, and everyone involved in the individualized therapeutic rehabilitation project. Is more important the natural network of the person we do. That allows a community and inclusive answer to the needs of people with mental illness. We describe the experience of the Emilia-Romagna region in the north of Italy. It is the region when we work. This slide shows the level of implementation in our region over the years. You can see the number is increased over the years from 2016 to 2020. Is a very interesting increasing. The next graphic show the state in 2020. How you can see the level of implementation is different in each province. That's why building an efficacy social and sanitary integration requires time and need to share the same vision and values. In this slide, and better in the graphic below, we can see how working and friendship and having satisfactory relationship are the most requested aims by clients, followed by housing. And then is the cost per years per local health company. Not all provinces are given their data, but those show us a reduction of cost. In the next, I think is better to see, because the costs are lower than residential facilities. In Italy, we spend for per person per year an average of 15,000 euro years. So the costs of budget of health is lower. In 2021, the Superior Institute of Health adopted the budget of health as the national methodology to realize individualized therapeutic rehabilitation project focused on the desires, needs, and values of people, and to realize the close integration between sanitary and social interventions to promote recovery process. The methodology of budget of health has showed a lot of points of strengths. The client is at the center of his air project. Sanitary and social integration is facilitated thanks to two elements: the individualized therapeutic rehabilitation project and the multidimensional evaluation unit. To contrast the institutionalization so people can live in their community. To promote a responsible community. The health is not a problem of sanitary services, but the community. Enhance the resource of the person and the community, and to reduce sanitary cost. At the same time, we are aware there is still a lot of to do, because to realize the budget of health, we need to change the culture about the mental illness and take on a new paradigm of care. We have to really overcome the medical model and stop to pay attention only to illness and symptoms. Person, values, and rights should be the words that orient our daily practice. To realize that, we have to find a new method, approach, and interconnection out of the sanitary systems. Thank you for your attention. Abbiamo fatto infinita. Non sono due presentazioni. Dottor Zandi.
We are still with, I've got a lineup of very exciting topics and excellent speakers. So our next topic is the subjective experience of substance use in people with severe mental disorders. And it's my pleasure to introduce our speaker, Dr. Germana Agnetti, who is the co-director of the IRIS School of Psychotherapy in Milan in Italy. Dr. Agnati is a psychiatrist and family therapist, and she has really a very interesting background socially and professionally. She trained in Milan, in Canada, in Australia, so a very rich personal and professional background. So over to you, Dr. Agnetti.
Okay. Thank you very much. Thank you for the presentation. My topic will be the subjective experience of substance use in people with severe mental disorder. Subjectivity is very important in rehabilitation because no adherence from user will be if there is no value of the program that we offer them. For that reason, my topic will be about subjective subjectivity. I want to do some general premise. Humankind always wished to protect itself, increasing its ability. And for this use the various tools, behaviors, prosthetic intervention, drugs, a variety of substances. The use of psychoactive drugs is a normal experience in our culture and involves around 90% of population, at least once in a lifetime. So the key issue is why and in which condition this usage becomes a problem. So we have to think one moment to the balance between desire and protection strategies. The relationship between desire and self-protection strategies is an important aspect of subjective experience, is based on subjective experience. And we have to keep in mind also the interaction between the user and what is used because this is a crucial point. Before going in deep in the subjective aspect of the use of substance, just have a look to the use of a substance and the addiction in severe mental disorder. And we see immediately in Italy, and we see immediately how it's heavy. Alcohol use 51%, but addiction 26%. Cannabis addiction 5%. Opioids 15 percentage of people suffering from severe mental disorder have an addiction of opioids. Huge. Cocaine 5%. 2% addiction of benzodiazepine not prescribed. And if we see the pattern of use about gender, is alcohol is the same, women and men. Cannabis is more in men, opioids more in men, cocaine is the same, benzodiazepine not prescribed is more in women. And if we go to the pattern of use characteristics related to diagnosis, we see that bipolar disorders and personality disorders are the ones who had access, are more inclined to use other substance, other out of alcohol. So we can say that mental disorder is a risk factor for addiction, a big risk factor, and this has an impact on mental disorder. So what are the risk why is a risk factor? We have to think in two aspects principally. One is related on emotion, high levels of stress, anxiety, fear, decreased perception of vital stimuli, emotional dysregulation. This is a cluster that incline people to have addiction. Another cluster is related to to perception, the perception of self and the perception of other. Negative self-image, low self-esteem, negative image of others, stigma, and self-stigma. All this increase the desire to change their own subjective experience in people suffering from mental disorders. So this is a big desire. Especially the negative self-image and low self-esteem is the most important factor, because attribution of value to self is a key issue in severe mental disorder, in all people actually, but in severe mental disorder even more. We all know the presence of low self-esteem in depression and bipolar disorder, and there are suggestions that psychosis might be related with a so big self-depreciation that it would be difficult for a person to be aware of. And this the negation, and but at the same time, the desire to have a prosthetic value to self. And for this, the person is compelled to use the substance to maintain minimal self-esteem. Now go to the other aspect of the balance, the drugs. Straight drugs partially reply to the necessity to change perception about self. They are appealing. They may increase feelings and emotions, may decrease stress, arousal, anger, may help socializing. So they are keen to be appealing for the person. And the destructive collateral effects mostly are not included in a narrative subjective experience due to the urge to acquire value to self-perception. So the issue of negative image play a role in making the person not aware of the collateral effects, side effects. Another aspect that I want to point out is the correlation between substance utilization and subjective experience. Specific substance reach specific effect. There are substances that reach effective regulation. Alcohol and substance depress the central nervous system, are often used against loneliness. Opiates against anger and aggressiveness, and also against psychological pain. Stimulant of the central nervous system against depression and low self-esteem, and are aimed to increase energy. This is related, this is balanced, but when there is stress perception of danger and substance utilization. Stress loss perception implies low subjective physiologic activation and therefore desire for stimulant. Excessive perception of danger implies too much affective and physiologic activation and desire for drugs able to decrease arousal. So this is why the self-protection strategies then doesn't function in certain conditions? Because self-protection strategy could make a balance between desire and the side effects. Attachment theories help us in understanding this. With the framework of attachment theory, they treated and pointed out that avoidant and ambivalent attachment patterns present in children as a reply to dangerous situation may over time becomes more and more complex, determining a distortion of affective and cognitive aspects on which subjective perception and reality evaluation are based. That meaning that people is not able to keep in mind their protection strategy, because there is a distortion of affectivity and cognition related to danger situation had in the past. So, what to do? It's not easy, but we have to consider some aspects. First of all, substance have positive aspects, and you have to keep in mind that. So positive aspects of a substance use are not present in prescribed drugs. So this is an important aspect. I saw the presentation of the first presentation, and I understood that psychedelic substances are more appealing than other substances prescribed. So this is why they are not appealing, because there are aspects of subjective aspects of this substance that are give more well-being to the person. So we have to ask ourselves, how can we replace this aspect and meet this specific patient's needs? How? This is an important question. Another aspect is need for implementation of psychological strategies to increase reflexive function, able to change dysfunctional self-protection patterns. So is need a work in metacognition that is very important in order to clarify the issue of self-protection strategies. Another aspect is the going down to historical aspect, able to bring to awareness and elaborate past situation of danger for self-image, because this can help the person to have a more realistic situation. What to do at the end? It's important that we have a psychological intervention and rehabilitation intervention synergy, because psychological intervention aimed at implementing reflexive function and mentalization have to be combined with rehabilitation strategy, because what we think cannot be apart from what we do. So it's necessary psychological intervention to implement reflexive function and mentalization. There is a need to discover and to value individual and subjective aspect attached to self-esteem. It's a need to understand what is the subjective experience of the person and value it. But there is also a need to gaining experiences in doing things, in the individually meaningful aspects of life that is different from every person. So this is an important issue, because only this is can favor self-efficacy, self-esteem, and in long term reduce the need for abuse, substance abuse. Thank you.
now with our next and final speaker for this session. And the lecture is entitled the Cure-All Psychosocial Rehabilitation Package Global Initiative for Childhood Cancer 2021. Our esteemed speaker is Dr. Manal Elewa. Dr. Elewa is a holder of PhD in Healthcare Environmental Management from USA. She's an OIDA therapist trained in Bulgaria, and she's done a diploma in art therapy in Ireland. She's also got training as a therapeutic art therapy practitioner and specialized in expressive art therapy and trained in Canadian International Institute. Dr. Elewa has been appointed as the World Health Organization Egypt representative for Global Initiative for Childhood Cancer, and she's also the founder and CEO of R2Care program. Over to you, Dr. Elewa.
Good afternoon, ladies and gentlemen. Thank you very much for allowing me to present this global initiative for childhood cancer. With you, Dr. Manal Elewa, the WHO CCI Egypt representative. I am the Egypt representative for the global initiative, and at the same time, I am also a family member, board member of WAPR. I'm also the panel advisor for Middle East Red Pencil Humanitarian Organization and some other organization helping children with life-threatening disease, with mental health problems, and with cancer. The learning objectives of these presentations are as follows. As I mentioned, as a family representative to the World Association of Psychosocial Rehabilitation, WAPR, as well as being a board member with the Childhood Cancer International, I taught as part of advocating for my cause, which is the support of children with cancer. I had to draw your attention to the efforts carried out in this respect. The objective of this presentation is to display the Global Initiative for Childhood Cancer, GICC, state of the art since inception and till today, aiming to reach about 60% of global survival rates by 2030, while reducing suffering and improving quality of life for children via psychosocial support and rehabilitation programs. A human face to the global market. I propose that the business leaders and we, the United Nations, initiated the Global Compact of Shared Values and Principles. That was mentioned years ago. And to start in 1999, to start for the SDG or the Sustainable Development Goals, which the world is part of it as MENA region, Egypt, Gulf region, we all participate in the Sustainable Development Goals. We are facing the health goal, which is the third one. The goals are 17 with a lot of benchmarks and other more complicated details programs. But we are mainly concerned today about the health, which is the third sustainable goal. The third sustainable goal is good health and well-being. Good health and well-being is covering a lot of issues, as you see mentioned here. And by 2030, the aim is to reduce 1/3 of premature mortality from non-communicable disease through prevention and treatment and promote mental health and well-being. So as you see, well-being, cancer, mental health is a trio all combined together. The partnership for goals also is our goal, because as physicians, as community levels, as volunteers, as business, as research, we all have to collaborate in order to reach our goal. The World Health Organization accordingly has launched the Global Initiative for Childhood Cancer, which says together we will save lives and make sure children with cancer get the care they need. That was mentioned by Dr. Tedros, the Director General. Cancer causes a lot of distress, sadness, tiredness, not sleeping, side effects, distress, confusion, angry, fearful, illness, not hungry, panic, a lot of mental health issues. The progress toward the SDG goals in the Eastern Mediterranean, which is our region, MENA region, is not being as hopeful as we were aiming to. The cancer burden and the risk factors are enormous, and we are all suffering from alcohol, from obesity, from tobacco, from HPV, hepatitis, air pollution, radon, radiation. A lot of factors can participate in cancer, and we are not on track. The track has been mentioned and clearly stated with a lot of initiatives and a lot of markers, benchmarkers, but we are 62 years behind schedule. Let's talk about childhood cancer facts. Cancer in children and adolescents is rare, but it is leading cause of death by disease. Each year, approximately 400,000 children and adolescents between the age of 0 to 19 years old are diagnosed with cancer. Worldwide, every 3 minutes, a child is diagnosed with cancer. And childhood cancer causes are 90,000 deaths per year. It is the leading cause of deaths for children. As I mentioned, 400,000 new cases diagnosed globally and 33,800 new cases estimated among the age between 0 to 14 in the Middle East region. That was in 2020. Although childhood cancer is curable for the majority of children when essential diagnostic, therapeutic, and supportive care services are accessible, profound inequalities in access and outcomes exist between countries, leading to as few as 20 or 30% of children living in low and middle income countries surviving. A lot of Zoom meetings along 10 years since 2011 until 2021, when the initiative was launched on February 15th. A lot of seminars, a lot of conferences, a lot of gathering, Zoom conferences, Zoom meetings, and between a number of organizations, let's name it, CCI is the Childhood Cancer International, SIOP, International Society of Pediatric Oncology, NDC, UICC, and many more. So let me take you into the journey of Global Initiative for Childhood Cancer, starting from September 11, which was the first meeting. And along in May 2015, putting the fight against childhood cancer was launched. Another meeting was done in 2017, cancer prevention and control in the context of integrated approach. In 2018, the first stakeholders meeting were launched. In time to deliver, the first time it was connected to the SDG goals, the Sustainable Development Goals, was September 2018. And then in May 2019, the forming of the working groups, which was after the Lyon meeting in October 2018, and the preparation of the cure-all package, which was started March 2020 and was launched in 2021. The cure-all for children with cancer is a global initiative, and the aim is, as I mentioned, by 2030, 60% survival rate of childhood cancer globally and reduce the suffering. Reduce the suffering means about saving 1 million additional lives, saving them from mental health problems, saving them from depression, saving them from suicidal attack. We have the goal, as you see on the left side, the objective, the outputs and activities, and the approach of the technical package. The approach of the technical package, all 4 levels between the centers of excellency and care network, universal health recovery, regimes, management and evaluation and monitoring, all involve mental health programs. Among this society, we have tried to gather the main issues about the problems facing the families. The Cure All projects focused on advocacy asks. So we had the serial number between 1 to 10, escalating from the countries within the EMRO and down to the strengthening and linking of the cancer registry and the population and the dashboard for childhood cancer population. So let's see about the focus of country, the pillars of action, and okay, so we are focusing here on the pillars of action on the national and regional workshops. These countries mentioned on the map had all run workshops for families with cancer and the stakeholders and the organizations in the region as well, covering the 6 continents. We started, it's all covered between 2019 to 2020 as example for the package, the Cure All package. As mentioned on May 8th, there was a 2-day national workshop, and the first interaction between the families and the objective of the GICC was elaborated and explained to the parents and to the medical staff as well. Followed by the New Delhi in June, that was in 2019 as well. Then on 2020, we expanded more and we had like 6 meetings and gathering and conferences between all parties related with pediatric oncology. Then in 2021, we had the launching of the initiative, and that was after a workshop of 3 days in January. Then the initiative was launched in February 15, 2021. The link is there, and we had presented all the activities for all the countries to be involved. Then a project was launched on April 22, proposal for technical assistance to conduct a rapid baseline assessment in all the countries involved in the initiative to cover the cancer health system and the development of action plan for childhood cancer control. Followed by dividing into work groups in June 2021. Then the second WHO Pacific region partners, the forum in 2021. Then last was the confirmation of 6 childhood cancer projects, which was endorsed by the Ministry of Health in the EMRO countries. The countries, we had 22 countries submitting their projects, covering mental health well-being of families with children with cancer. And the winning were 6 proposals successfully from Iran, Iraq, Jordan, Pakistan, Palestine, and Yemen, among 96 participants. The Cure All framework and its accompanying technical package were used to develop and to support implementation of the initiative. The package is intended to help countries assess their current capacities, set their priorities, and generate investment cases, develop evidence-based standards of care, and monitor progress. An information sharing portal has also been created to facilitate sharing the expertise between countries and partners. We had the following slide, which says about childhood cancer. In high-income countries, 80% will survive, the children with cancer, compared to in low and middle income countries, 20% only survive, and that was the bottleneck. The drivers of cancer burdens are enormous and are covering everywhere. Setting priorities also, breast cancer was among the issues in addition to childhood cancer, and there was a WHO reported on cancer in general. With comparing the countries, breast cancer screening without treatment by income. In some countries, they only have screening and they don't have treatment, which is another problem. Coming back to the WHO Global Initiative, as I mentioned, 20%, 80%, the global strategy to accelerate the elimination of cervical cancer as well. All these initiatives are covered through advocacy, training, and strengthening the capacities of the medical working staff, as well as the families. The global initiative also has now 40 countries from 4 different regional networks. We have more than 120 partners in the initiative, and we are covering more and more specifically targeting some countries and some groups with the public and the government hospitals. Coming the legislation, which is also coming along with the same workforce and the innovation, and as well as medicines. Now let's talk about Egypt. Egypt has a number of governmental hospitals working with cancer hospital, between research, between treatment, between adults, and between pediatric. Quite a good number, scattered in all the governments and all the country. Then comes the hospitals, the children, or the specific hospitals for childhood cancer are only 5 centers in Egypt, 57357 in Cairo, and Ayadi al-Mustaqbal in Alexandria, Hewa Khafaji Center in Cairo, 500 under construction, and the branch of 57357 in Tanta. Those are dedicated to childhood cancer and free of charge. Treatment is given free of charge for the patients. There are also a number of NGOs for helping families and for cancer, adults as well as childhood. And this is the profile of the country in 2020. The PD cancer country profile in 2020 also, they listed the acute lymphoblastic leukemia as the highest rate of diagnosis. Hodgkin lymphoma, Burkitt lymphoma, CNS, retinoblastoma, Wilms tumor, and other childhood cancers. Let me take you along a quick tour with the psychosocial rehabilitation programs that are carried in Borg Al Arab University Hospital. Let's take the pictures from left to right. We are covering the patients as a holistic. So we do programs, psychosocial rehabilitation programs for the parents, father and mother, for the siblings, for the patients themselves. On the other side, we do also psychosocial rehabilitation or relaxation or some meditation, some art therapy workshops for the medical staff as well as the administrative staff in the hospital. So these are some of the workshops carried on between the patients, between the staff, and between the medical staff, and between the parents as well. You can see how much appreciation is happening, especially the mother. Also, we carry something very nice with the parents are liking. We do art therapy workshops between parents and their sick children at the same time. So you can see to the right hand, this was a workshop between the daughter and the mother at the same time doing an art therapy workshop. We do also mindfulness, we do yoga, and we do relaxation. And this is also before we start the workshop. So in the middle, we are also doing some workshops with adolescents, which is their fingerprints for their life since they were diagnosed until where they stand. We introduced also some of the games. You know, we play with with the kids as well as the medical staff. We do kind of group activities and group fun for them. These are my references, and this is where you can reach me. I'm here with you, ready to answer any queries or any questions. Thank you very much.
I just want to have a consideration to put to the judgment of Dr. Agour about his presentation that I liked very much. Just thinking about psychedelic drugs that can be too appealing for the person. So of course, that is a good thing, because the person who appeal the therapy don't withdraw from the therapy. Withdrawing of therapy is a major issue in this moment for our therapy. So this is a good thing. But on the other hand, my doubt is about the possibility to enter in an addiction. Because we have to be aware of what happened, especially in North America, with the opioid prescribed for the pain. So I would like Dr. Agour to give some thinking about that, if it's possible.
Thank you very much for the question. So if you're referring to the addiction potential for psychedelic drugs, the current really literature review suggests that if they're used under therapist supervision with the right doses, it does not really cause addiction. This is the current scientific position. And in fact, one of the unique modes of actions about psychedelic drugs is you don't usually need to administer them on a daily basis. If you do, they don't take effect. So it tends to be one session, then the person may have a break for a week, 2, 3, or even a one-off session that leads to the therapeutic effect. And it is hypothesized that the therapeutic effect through ego dissolution, weakening and loosening of the maladaptive schemas and beliefs, and then that is followed by psychotherapy. So that's why it's always referred to in the modern literature as psychedelic assisted psychotherapy.
Thank you. Thank you very much.
You're welcome. So obviously, I'd welcome the audience and the speakers if this is the time to ask questions, and if you need to clarify any other points. We've had obviously a number of interesting topics, and if I were to ask a question, Again, it will be to do with the subjective experience of substance use disorder. So I'm asking Dr. Agnetti, in your practice, have you come across people who've been abusing psychedelics? Because here in the UAE, I've been practicing for the last 5 years, and it's very, very rare when people tell me that they abused it, and if they have, they usually didn't like it because it didn't give them the high they expected to get from stuff like methamphetamine or the numbness they would get from stuff like opioids. So I really want to know from Dr. Agnetti and other colleagues who've come across populations with substance use disorder, if psychedelic misuse is a common thing, and if it is it in conjunction with other substances?
the possibility that a person go to street drugs, and because they are more appealing to change the, especially in young generation, of course, because it's more appealing, and they have apparently immediate well-being from that. Of course, as I suggest before, this is partially due to the balance between the desire, that is to change immediately my own perception, with my self-protection strategies that are not always, because of previous experience, well set. And in this moment, I am not able to value, to give the right value to the collateral effect, to the side effect, to the side effect in long term. But I value more the immediate well-being that this substance gives to me.
Excellent. Thank you very much. Any more questions from the audience or from any colleagues?
I have a question. I have a question for Germana. Hi, Germana. I want to ask you what training must do the practitioners in mental health services to increase, to promote the subjective experiences of users?
Well, it's quite difficult for me to reply to this question, but I think that a practitioner have to have some rudimental aspect of psychotherapy, and of course to know the self-protection strategies, and also need to have something that is more a personal aspect than a technician aspect, that is a real respect for the value, respect the idea of the users. I think, I don't know if I replied correctly, but I think these three aspects are important. I heard yesterday Patricia Deegan speak about the adherence, but it's not the right word, adherence, that the way the relationship between the user and the drugs, the prescribed drugs, in which she pointed out how the subjective experience, she didn't use this word, but it was that, the subjective experience of the person play an important role because the individualistic, the individual, not individualistic, the individual goals have to be valued also from the by the professionals. I don't know if I replied, but I hope so.
Excellent. Can I ask a question to Dr. Manal? So I know obviously you and your colleagues are doing fantastic work in the areas of helping with the early diagnosis and treatment of cancer, particularly children. Now, just trying to find some overlapping between your area of expertise and what I'm interested in the psychedelic medicine. Are you aware that some of the past studies and recent studies on psychedelics have shown that it helps reduce significantly the anxiety and the depression that can accompany terminal illnesses like cancer, and bearing that in mind, could that sort of be a joint piece of work with your team, or are you more focused on the increasing the survival and the cure rate, and not particularly the sort of the comforting or the management, the palliative care? That is what I'm looking for. The palliative care for people with terminal illness. I can repeat the question or rephrase it again if you want, Dr. Manal.
I couldn't hear you very well, but I think you were asking about the palliative care's efforts.
Yeah, is palliative care part of what you do, or your main focus, you and your team, is on increasing the survival amongst cancer sufferers?
I have to be honest with you, it should be part, but coming to the culture or the customs of the people where we live in this part of the world, it is very emotional to have, like centers for palliative care, because the families, they take care of the patient.
Okay. Well, that's really good to hear, because as I said, there are in many parts of the world, particularly the Western societies, they found
the care is given by the families to their members, members of the families. We should have palliative care training for people, especially the medical staff. It is possible in the hospital.
Indeed, if you ever think of a project along those lines, as I said, there is past and current good evidence of psychedelic drugs easing significantly the severe anxiety and depression that accompanies terminal illnesses, provided that your obviously first line psychosocial interventions didn't work. That could be a third line to add to the efficacy of the psychosocial. Talking therapy, psychosocial interventions are always the first line when it comes to mild to moderate psychological problems. But yes, I definitely take into account your point about that in our countries. our cultures, the family do a lot of the palliative care themselves. Thank you very much for that. We have a couple of more minutes for final questions or comments from the audience or the speakers.
Thank you very much to all the speakers for their interesting and informative presentations. As research on the use of psychedelics for treatment of mental diseases is of particular interest of mine, I direct my question to Dr. Magid. As I understand it, the use of psychedelics for treatment of disorders such as depression or anxiety lies mainly in their utility of inducing a cathartic experience, which may trigger the remission in the patients or subjects. I imagine that prior to this episode, this psychedelic episode, there is a sort of preparation that the subject would undergo under supervision of psychiatrists or psychologists in order to maximize the chances of having a cathartic experience and minimize the chances of having a traumatic or what is called a bad trip. So my question is there a preliminary framework to how this may be done by the psychologist or the psychotherapist? And is there an eligibility or exclusion criteria present for picking the subjects?
Excellent questions. Just remember that none of the psychedelics are currently licensed for any clinical indication. And perhaps the only exception for that, and I cautiously mention it, the S-ketamine is thought by some academics and some authors as a quasi psychedelic. It's a cousin of ketamine. And some people, some authorities consider this will pave the way for the other psychedelic drugs to be licensed in due course. But on that note, just to point out, the recommendation of esketamine being the patient being supervised for a couple of hours after the introduction of the nasal spray, not for psychotherapy, it is to monitor for side effects. The past and the current work on psychedelics focuses on psychedelics plus psychotherapy. Yes, there is a lot of preparation in terms of psychological preparation. And remember, I would like to think, well, the current research is not really on people who've got mild to moderate psychological problems, which usually respond to the mainstream orthodox psychiatric interventions, CBT, SSRIs, and so on and so forth. So the studies really are focusing on the people with kind of treatment-resistant conditions or chronic conditions like substance use disorders that with the best current interventions, biopsychosocial interventions, for example, an opioid use disorder with treatment, your relapse rate is 80% in the first year. Without, if it is just a psychosocial intervention. If you add medication-assisted treatment like opioids agonists like buprenorphine or methadone, your relapse rate reduces from 80% to 50%. Still not very satisfactory. So the studies really are looking at these very, very severe cases. And yes, people will have had lots of psychosocial preparation, ongoing psychosocial interventions and support. I think there was a latter part of your question.
Yes, I was wondering if there is any preliminary eligibility or
exclusion criteria. I think at the moment, psychosis. Psychosis is one of the big exclusion criteria at the moment. You're welcome. Thank you very much. So I would like to, we've come to the end of the session, and I would like to thank our esteemed speakers for very informative and thought-provoking talks, and I would like to thank the audience, both in person and virtual, for attending, and enjoy the rest of your day. Thank you very much.
Good afternoon, everyone, or good morning if you are in another part of the world that's morning. My name is Dr. Tal Qasim. I'm a consultant all day psychiatrist and will share this session with you. We'll have two talks. So the first talk is advances in Alzheimer's disease. So this is the first talk, and the second talk will be by Dr. Madam. Each talk will take kind of around 30 minutes or so. So I would like to welcome you in this session. As I said, I'll be talking about research on diagnosis or management of Alzheimer, and Dr. Madam is going to talk about assessment of total disability in presence of multiple disabling conditions. Will be presenting virtually, so I'll start my talk now. So this is me. As I said, I'm an all-day psychiatrist. I've been practicing all age nearly since 2007. I'm the lead for all the adult services in Dubai. And in addition to my clinical role, I have academic interest. I've published on the topic. I have a particular interest in validation of tools in assessment of dementia. So the learning objective today, we will talk about basic pathology and pathophysiology of Alzheimer's disease, diagnosis. Most importantly, we'll talk about new treatment, especially the treatment that was approved recently by the FDA. Before I start, I need to just put my disclaimer that I have not received any compensation or honorary from any pharmaceutical company on the drugs that I mentioned, or otherwise that I have no direct relationship with any manufacturer of the drugs discussed. So just to say that if dementia was a country, this country would be would have 58 million inhabitants with a newcomer every 3 seconds and a population that's doubling every 25 years. And by 2050, it would have 130 million inhabitants. It would rank number 17 with regard to GDP or the cost of dementia. And the GDP or the economic burden of the disease would cost $1 trillion. And just to put things in context, $1 trillion is the GDP for Saudi Arabia, Kuwait, Bahrain combined. And 6% would have Alzheimer or dementia. So just talking about it. Okay, so we'll talk about the pathology in Alzheimer's disease. Alzheimer is a type of dementia. It's the most common type of dementia. It's, as I said, it's 60% of the cases we see with dementia. So basically, the pathology is there are two pathological findings in dementia, two core pathological findings in Alzheimer's disease, which is accumulation of extracellular amyloid plaques and intracellular neurofibrillary tangles, and both of those cause atrophy or cell death, neuronal death, which result in this gross picture, which is atrophy in specific parts of the brain to start with, and then it becomes global or generalized. So start with atrophy of the medial hippocampus, medial temporal lobe, and then spreads to the rest of the parts of the brain. So this is a schema of the pathology or the pathophysiology of Alzheimer's. So start with accumulation of something called beta amyloid or amyloid beta protein. It accumulates between cells. It induces phosphorylation of something called tau protein. This is intracellular that disrupt the microtubules in the neuron, causes neuronal death, which manifests clinically as cognitive impairment. If we talk a little bit about amyloid, beta amyloid or amyloid deposition. Basically, there are three types of the beta amyloid. There's the good or the common, which is beta amyloid 40, which the cleavage site is amino acid number 40, the good, and the bad, which is AB42, the cleavage site is at the amino acid 42, and the very bad, which is fortunately a rare form, where the cleavage site is on amino acid 43. So when there is accumulation of beta amyloid 42 and 43, they accumulate extracellularly and they induce the following, which is phosphorylation of tau protein intracellularly that causes neuronal death. So this is a summary of the pathology, just to say that insulin plays a role, and that's why Alzheimer's disease is sometimes called diabetes mellitus type 3. And the reason for that is there is increased resistance to insulin, which plays a role in the deposition of beta amyloid and the inflammatory process, as well as the phosphorylation of tau protein. So the treatment timeline has been placed since the 90s, where we started to have treatment for Alzheimer's disease. They were toxic at the beginning, so there were tacrine and other things, cholinesterase inhibitors, and then medication started to be more refined. And in 2000, early 2000, we had memantine, which is non-cholinesterase inhibitor, and then things started to stall. There was no approved medication in spite of a lot of trials until June, July this year, when we had breakthrough approval by the FDA for monoclonal antibody called aducanumab. We'll talk about it a little bit more. So if we want to tackle the natural history of Alzheimer's disease, if we're talking about primary prevention, the aim of primary prevention is to prevent the deposition of beta amyloid in the brain. So this is first target. If we're talking about secondary prevention, we would like to remove the beta amyloid and prevent the formation of phosphorylated tau proteins. And tertiary would be removal of phosphorylated tau protein. This journey kind of takes 25 years, because the pathology of Alzheimer's disease starts way before the symptoms start. It starts 25 years preceding 25 years preceding the start of the symptoms, and start with accumulation of beta amyloid that triggers phosphorylation of tau protein, and that triggers neuronal death. And this journey takes around 25 years. CADRO is the Common Alzheimer-Related Dementia Research Ontology. It's a classification, if we're talking about what kind of research is taking place with regard to Alzheimer or dementia. So most of the talk today will focus on category A, which is molecular pathogenesis, physiology of disease, of Alzheimer's disease, as well as treatment. At the start of the year, if any of you went on clinicaltrial.gov, he would find that there is 126 agents registered for Alzheimer's disease, and that attracted kind of shy of 40,000 participants on those trials. Of the 126 agents, there was 152 trials. 28 of those agents were in phase 3, and 74 were in phase 2, and 24 were in phase 1. If we talk about really the kind of medications or the agents that were running, so disease-modifying agents are the agents that tackle this pathogenesis we talked about, the beta amyloid and the phosphorylated tau protein. So 80%, roughly 80% of the agents aim to tackle this pathway. 10% of the agents were cognitive enhancers, and around 7% plus were tackling the behavioral psychological symptoms of dementia, otherwise known as neuropsychiatric symptoms of dementia. And just speed forward to June the 7th, where we heard that FDA approved a new drug. It was a breakthrough. It's a monoclonal antibody. It's a disease-modifying agent. It's called aducanumab. And just to say that it is, as I mentioned earlier, it is the first of its kind in 20 years. How it works, it's monoclonal antibody. It tackles beta amyloid. So it crosses the blood-brain barrier, attached to the beta amyloid, dissolve it, and get it out to the bloodstream. We said that the initial approval came in June. However, the license for the medication was limited in July to only include MCI, mild cognitive impairment, and mild dementia due to Alzheimer's disease. There was exclusion for moderate to severe Alzheimer's disease. Just to say, if you are interested and go on the clinicaltrial.gov, you will find that the two trials that were based on the approval were terminated, and if you can read terminated, study was discontinued based on futility analysis done, not based on safety concerns. So according to clinical trial, the two trials of aducanumab failed to show success in outcome. And we will talk about that in a minute. So there were two big trials, the EMERGE, the ENGAGE, and then the EMERGE. And the approval came based on subgroup analysis. So if we see the trial, so this is the control, this is the active participants, we took the active ingredient, we can see that there is significant reduction in beta amyloid load with regard to the doses administered. So this is the 3 milligrams and this is the 10 milligram per kilogram. And we can see the difference. So definitely there is a high chance that this medication reduces the beta amyloid. This is evident, we can see that. The issue is the efficacy. So we only show effect at the dose of 10 and in one trial, which was the EMERGE. And the effect wasn't reversal of the symptoms, but was slow progression of the illness. And that came on one subtest. So this is the ENGAGE, this is the first one, and we didn't see any change in the scores, CDR, clinical dementia rating, some box test, and the EMERGE. The only difference was in this subscale, and the difference was 20% reduction of the progression, the speed of progression of the illness. And on those bases, the FDA approved the aducanumab. What about the side effects? The aducanumab, like the rest of the monoclonal antibodies that are designed to tackle beta amyloid, they suffer from the same problem, which is amyloid-related imaging abnormalities. So there are two types, type E, which is edema, and type H, which is hemorrhage and hemosidrosis. So the area E, we see that really a third of the patients have area E who had aducanumab compared to 3% of the placebo. So that's tenfold. And the area H, which is amyloid-related imaging abnormalities, hemorrhage and hemosidrosis, it's threefold increase in the active group. Common side effects, headaches, falls, it's not a significant difference, diarrhea and delirium. So this is the area E, the area edema, and this is flare. So this is MRI flare, and we can see the edema affecting part of the brain. So what happens is there's disruption to the blood-brain barrier, and this area A could happen up to 80% of the patients. Luckily, a significant proportion of patients have kind of mild symptoms or asymptomatic, but in some occasions, I think 20% of the patients, they may have severe symptoms. And this is the area H of hemosidrosis and hemorrhagic, and this is T2 star, MRI T2 star, and we can see the hypointensity here, those small dots, those are microhemorrhages, and they tend to happen as a complication of the monoclonal antibodies or aducanumab in this particular case. Other confounders other than the aducanumab, we know from the trials that ApoE plays a role. So patients who have ApoE4 haplotype, they are at much higher risk of having ARIA, so kind of fourfolds between moving from 10 to 40. This is the overall population, not those who have ApoE4. However, if we look into ApoE4 carrier, the percentage of them having ARIA is 43 compared only to 4%. So this is 10-fold increased risk. So we spoke about the medication, we spoke about how it works, we spoke about the side effects, which are ARIA E and ARIA H. And now we need to talk about appropriate patients, because as you expect, a lot of patients and caregivers for patients will be very keen to take or to explore that medication, the aducanumab. So it's only licensed for mild cognitive impairment or mild dementia of probable Alzheimer's disease. It's not for the rest of dementias. And for a person to qualify for this, he or she needs to score at least 21 on many mental states or more, and on CDR, the clinical dementia rating scale, half, not more. Also, we need to have evidence that this pathology or this illness is caused by beta amyloid pathology, and that's why we need beta amyloid tracer, or we have beta amyloid load in the CSF. Genetic testing is highly recommended. It's not in the insert leaflet of the medication produced by the company, but working consensus group, as well as different groups in the States, have strongly recommended having ApoE4 study, because there is a double risk of ARIA with ApoE4 carriers. Those who have significant neurological illness, medical illness, or psychiatric illness, they may not qualify to receive this medication. Also, those who have high risk of hemorrhages should not qualify for the medication, or those who are on anticoagulants. But there is no problem for patients who receive cholinesterase inhibitors or memantine. How it is administered, it is monoclonal antibody, so it is IV. So the first and second infusion. So each infusion should happen monthly, or the space between each dose should not be less than 3 weeks or 21 days. We start with 1 milligram per kilogram, the first 2 infusions, and then the third and fourth 3 milligrams, and the fifth and sixth 6 milligram, and the seventh infusion 10 milligram. And at 10 milligram, patients at high risk of having ARIA, and that's why we need to have MRI. So we need to have MRI at the start. We need to have MRI if there is any symptoms suggested. before the 5th dose, before the 6 milligram, and before the 10 milligram, and the 12th, or if there is any other symptom. If we find ARIA, if the patient is asymptomatic and it is mild, we can continue and monitor with MRI. If moderate to severe, we have to stop. Or if it is symptomatic, we have to stop and redo the MRI. If symptoms persist, then we should not continue. And if symptoms resume and there are no, so if the ARIA disappears and there is no symptoms, then we can restart. Just to say that along the process, we need to monitor the patient cognitive functions with Mini-Mental State or any other suitable test, because once the patient moves beyond mild dementia, there is evidence that the medication is not going to help and the risk of having side effect is going to increase. So the risk-benefit ratio flips. Also, the aducanumab should not be used for any other type of dementia other than Alzheimer, should not be used until now for any condition that have high beta amyloid load. There is no evidence that it helps in moderate to severe. There is evidence that it makes things worse. And patients with cerebral amyloid angiopathy, they are at high risk of having hemorrhages. So in summary, this is the first medication, first drug in 20 years. It has been approved for mild cognitive impairment and mild dementia due to Alzheimer's disease. We know that the medication is effective in reducing the beta amyloid load. We know that it doesn't reverse the symptoms. So we know those two things. We think that there is delay in the progression of the illness, at least shown by one study in one subtest. And we know that it has side effects that could be serious. The challenges with this class of drugs is it needs a lot of infrastructure. It needs PET and amyloid tracer. We need to repeat MRI, we need genetic testing, and we need experienced neurologists. We talked about the area, the amyloid-related imaging abnormalities. We talked about its two types, the area E and the area H. And those conditions need to be monitored closely because they could be devastating. Percentage of patients could move to hemorrhage, especially those who have area H. So this is a summary of the progress of the treatment of Alzheimer, focusing on the recent advances and recent approvals of the medication aducanumab for Alzheimer's disease. And I'm happy to take questions if there are. Good afternoon again, everyone. It gives me great pleasure to introduce Dr. Madan, who is a fellow in Psychiatric Rehabilitation Service at the National Institute of Mental Health and Neuroscience in Bangalore, India. He is an associate professor of psychiatry, and he will be talking to us about assessment of total disability in presence of multiple disabling conditions. So without further delay, Dr. Madan.
Myself, Dr. Madan R., pursuing fellowship in Psychiatric Rehabilitation Services, Department of Psychiatry from National Institute of Mental Health and Neurosciences, India. Topic being presented is assessment of total disability in presence of multiple disabling conditions. Learning objectives. To discuss the limitations in using the notified guidelines by Ministry of Social Justice and Empowerment for measuring total disability in persons with multiple disabling conditions, and to illustrate the limitations through hypothetical examples. Also, to discuss the alternative approaches for overcoming the described limitations. Introduction. A total of 20 conditions are described as disabling under the Rights of Persons with Disabilities Act 2016. Specific guidelines for assessment of disability due to each of these conditions are notified by Department of Empowerment of Persons with Disability under Ministry of Social Justice and Empowerment on 4th January 2018. To measure total disability in persons having multiple disabling conditions, a formula A plus B into 90 minus A divided by 90 is recommended, where A will be the higher score and B will be the lower score for the disabilities. The maximum percentage of total disability cannot exceed 100%, and the benchmark disability, which is minimum 40%, has to be there to avail or register under Rights of Persons with Disabilities. Higher degree of disability would be eligible for higher degree of supports and allowances under the schemes. Assessment processes aimed at measuring total disability can impact persons with disability access to these various support systems availed by the schemes. Method. In-depth analysis of disability assessment guidelines issued by Ministry of Social Justice and Empowerment dated 4 January 2018. Also, analysis of procedure adopted for measuring total disability in Israel. We have used 3 hypothetical examples to illustrate this problem. The first example being Mrs. A having mild intellectual disability corresponding to 60% of total disability and moderate hearing impairment corresponding to 50% of disability. Second example, Mr. B having intellectual disability of 90% and cerebral palsy causing locomotor disability of 50%. Mr. C has locomotor disability of 90% and hearing impairment of 90%. Results. By using the formula notified by Ministry of Social Justice and Empowerment, A plus B, 90 minus A divided by 90, total disability in Mrs. A would become 65.5%. That is, 5.5% has been added to the first disability, which is 60%. Mr. B, wherein he has 90% and other disability 50%, applying the formula would still remain the total disability as 90% because of the limitations in the formula. Also, in the case of Mr. C, where the first disability is 90% and also the second disability is 90%, but still the total disability using this formula is still 90%. So seeing these hypothetical examples, what is understood is that a person having 90% or more as his first disability would not benefit from other disabilities as there is limitations in this formula. And as we can see, lesser than 90%, like 60% or 70%, it would not cause any problem or error in this formula. As this is the only notified manner in which total disability should be assessed in persons having multiple disabling conditions, for a general population for about 1.2 billion and estimated 25 million with one or the other disabilities in India, this limitation can pose significant barriers to multiple stakeholders, especially person with 90% disability due to multiple disabling conditions. And this can cause potentially underreporting as the persons with 90% disability would not reach out to any centers or feel less motivated as they know that other disabilities can't contribute. As on 19/11/2021, like Government of Telangana reported total number of persons with benchmark disability as around 8 lakh, corresponding to 2.1%. However, Among this, persons with multiple disability reported were only 3,285 people, which is in the fraction 0.009%. And one more statistics, like based on the population estimation, 2011 indicates that among 2.21% of total disability, 8% has multiple disability. So these areas has to be looked up and researched further why there is huge difference or underreporting of multiple disability. Suggested alternative: a procedure adopted by Social Justice Department of Israel for measurement of total disability is a worth alternative to be considered. In this system, a formula to calculate total disability is A plus 100 minus A into B divided by 100, where A is first disability and B is second disability. Using the same three hypothetical examples, in the case of Miss A, like the total disability percentage amounts up to 89%. And in case of Mr. B, its total disability is amounting to 95% and 99% in Mr. C. So as we are seeing here, like 90% or more is not being causing any error in the formula, and almost 5% to 9% of disability is adding. So to conclude, in view of these limitations posed by the formula notified for measuring total disability, there is a greater need for exploring more alternatives. And our current guidelines do not suggest any of the alternatives to overcome this difficulty. So the formula used by the Social Justice Department of Israel seems a suitable alternative in this regard. So these were the references used. And thank you.
Thank you very much. Thank you, Dr. Manan, for your presentation. I like the mathematics. I like the formula that you showed, especially with regard to the two conditions of disabilities. I wonder if there are 3 or 4, how does it work?
Yes, sir. These were hypothetical examples used for the 2 disabling conditions. But in India, like the same formula, if 3 or more disabilities are there, like from the same thing is used for the first and second disability. We will get a total percentage, and then the total becomes the 1% with the next third disability. So here the combined formula will be used again the third, where this like A and B will become 1%, and that will be compared with, say, using the same formula, we'll use it the third one, and subsequently it keeps on going where the percentage can't exceed 100%. Till the last disability, the formula keeps.
I wonder if the floor have any question.
Hi, my name is, thank you very much for the interesting concept of these formulas. I have just a couple of points to make. First, what are the outcomes decided based on the result of these assessments? And this might answer my second question, or my second comment really, which is there is someone making the initial assessment for these individual disabilities. Wouldn't it be better to manage something which is qualitative in a less quantitative manner by maybe allowing this initial assessor to do maybe a holistic assessment of all disabilities and come up with a decision, whether it's financial or rehabilitation or care or whatever?
Thank you very much. I think this question goes to you, Dr. Madhan.
So, pardon, sir, can I get, it was not clearly audible to
all
me.
right, okay. So,
It's very
first,
feeble.
yeah. So, I'll rephrase and simplify my point really. So, basically, this equation, or this formula decides the level of disability, and I'm sure there will be some implications like financial or treatment planning or rehabilitation implications based on the result of this formula. So my comment is instead of using a quantitative method to assess something very qualitative, because it can change based on each individual experience with each disability, would it be better for the initial assessor who assesses, who has the duty of assessing each individual disability, to maybe make a more holistic assessment of all disabilities and come up with an individual percentage or number to decide the level of support needed for each individual?
Yes, sir. Thank you for the question, sir. It is a very sensible like pointer to be noticed, and in our experience, like this is a major challenge in the like the setups or the institutions where the patients go. For example, ours is a National Institute for Mental Health, and other disabilities, neurological disabilities like locomotor disabilities can be added up, or multiple illnesses related to mental health issues can be added up. But being the patient, since it is a Ministry of Justice, or like there are certain organizations or the government setups where the patient has to go around, so it is not feasible for them. So it would be a future aspect where, as you suggested, like like the treating physician or the treating therapist can assess all the guidelines and do that. But if the same person is visually handicapped or hearing impairment, so the system should also have a treating ophthalmologist or an otorhinolaryngologist to be attached to assess the disability. So where it becomes a challenge in setups where there is like NIMANS is focused only on like mental health and neurological issues. So yes, sir, that would be like in future scope, like to add, so that the person can't roam around or like go to the multiple centers and again certify with through different portals becomes a challenge to the patient. So addressing like what you said would be a better option, and we look forward so that government can make such changes or such beneficiaries for them to access at one point, sir.
Okay, thank you.
Is there any other question from the audience?
Oh, thank you. Thanks. Thank you.
Thank you very much.
Okay, sir.
If there is no other question, I think we will conclude. Unless you have anything else you would like to ask about. To be honest, I expected people to ask me about how a medication got license for marketing in spite of failing the 2 trials that have been conducted. I was so eager to hear that.
I have another question about the medication, if you don't mind. Yes, I've been following the debate and some articles, especially on the BMJ and how they criticize the process, and it's actually was a quick way of approving the medication. But you know, having listened to your interesting presentation and having worked in the UAE for a year, I have like a parallel idea of why not use the infrastructure needed, especially its license now in the UAE, bring it on and maybe give it a try and use the infrastructure or use this new medication to establish a better infrastructure for the general care of people with Alzheimer's. Is Dr. Tariq still? Disconnected? Okay, I'll repeat the question. Hi, Dr. Tariq, it's Dr. Sharif again. Hi. Yes, we're aware of the process of approving the medication, and I'm aware it's already approved in the UAE. I was wondering if you're aware of anyone or any hospital who have already started using the medication. And the other thing is like by trying or starting to use something that's already approved, I was hoping to maybe use this very strong infrastructure needed for this particular medication to improve the general infrastructure available for diagnosing and managing Alzheimer's disease.
I like that, because usually the resources that are used for one condition could be used for several other conditions. I've been working in old age here in UAE for 2 years, and in my capacity as head of department. I'm still yet to see neuroradiologists who have interest in dementia. I still yet to see any of the advanced neuroimaging techniques that I had in the UK. So the fluid here, the amyloid tracer, the tau protein tracer, all of those things were available there, they're not available here. And it's not, again, about bringing the material, it's about bringing the expertise who are able to read or interpret those results. So it's never been about just the material. So this is one thing. The other thing, this medication, it does not revert the course of the illness. This is clear. It does not. The best thing that it could, or it's possibility, it's not a probability even, could do is slow the progression of the illness in one subtest among a lot by 20%. So this needs to be clear. And just for those who are interested in the pathophysiology of dementia, yes, the beta amyloid is a common feature in Alzheimer's. We can all diagnose Alzheimer's if there is beta amyloid, but a lot, not a lot, but it's not certain that removing the beta amyloid improves the progression of the illness, because we think that it's not the beta amyloid, it's the tau protein that has a crucial role in causing disruption of the neuronal function, and that's why it's still very unclear. And just to say something about this panel, so the advisory panel on the aducanumab, it's constituted of 10 people. I think, don't quote me on this, but at least 5 of the 10 people, at least 5 resigned upon the decision of the FDA to approve that medication, because this is the first in psychiatry, a medication that failed 2 trials get approved, because this class of medication have been tried several times. So there's a huge number of those similar molecules that have failed on the same test, and afterwards they were not approved. I think the change is not the change in a medication, it's a change in vantage point of the licensing body. So previously, they used to treat Alzheimer's disease or dementia as the endpoint that shows improvement. Now, the reason why they have approved it is like cancer, because they do that in cancer. So if a medication, if a molecule, if a drug, if an agent proved to have some effect on one parameter, biological parameter, not a clinical parameter, biological parameter in cancer, they tend to approve. So again, it's not a breakthrough in something that has not happened before. I've been in several trials and this happened, but the medications were not approved. And I think that will open a door to some of the manufacturers who had tried their medications to be approved and have failed to reapply again based on this, this case. But the change is, again, a change in how the FDA sees the aducanumab. Again, the European Medicine Agency hasn't approved it. It is not approved in the UK.
Yeah. Thank you very much. I've followed, I've read an article in the BMJ, I think in July, highlighting all the criticism around the approval. But just a point to reflect on, and because of the cost, so the funds around this new intervention might be a factor that help attract all the expertise, as you mentioned, the genetic testing, the neuroradiology, and establish a general better resources for Alzheimer's in general.
I'll just comment on that, because this medication costs annually $54,000, okay? So we will pay $54,000 per patient for a year. For $54,000, we can prescribe physical exercise, which is proven to work as a disease modifier. There is an unequivocal evidence to support physical activity for patients who have dementia that not just only improve a biological marker, it improves their sense of well-being, it improves the rate of progression of illness, it improves frailty, which is a common thing that they suffer from, it improves all sorts of other parameters that exceed beyond an image of an MRI or PET scan. Though I would love to have an infrastructure of multidisciplinary team who are highly specialized, I think this funding could be used more efficiently.
Thank you very much. Thanks a lot for your comments.
I think if we don't have any other question, that will conclude our session.